Welcome. I hope your day is going great. The objective of this presentation is to recognize appropriate and inappropriate drug treatment for each phase of bipolar illness and recommend drug-specific monitoring parameters. This case represents a common presentation. Patients with bipolar 1 fluctuate between phases of acute mania, which includes exaggerated self-esteem, sleeplessness, pressured speech, racing thoughts, distractibility, agitation, risk-taking, and it may include psychosis and/or require hospitalization. It also includes depression and euthymic stable mood phases. Patients are functionally impaired. The symptoms of a manic episode tend to be so obvious and intrusive that there's little doubt that something is wrong. Patients with bipolar 2 have at least one episode of hypomania, which is mild manic episodes of short duration without psychoses or need for hospitalization, and at least one episode of depression. These patients spend more time in the depressive phase than bipolar 1 patients. A person experiencing hypomania will exhibit manic symptoms but is able to continue with day-to-day responsibilities and may even see an increase in job performance or other goal-directed activity. Our case study has had at least 2 episodes of depression and 3 manic phases. She demonstrates many of the symptoms of mania, but has not had psychoses or hospitalization. These recommendations are according to the International Society for Bipolar Disorders 2018 guidelines, as the American Psychological Association guidelines are rather old and don't reflect current knowledge and practice. This slide includes a list of drugs in the order of preference used as monotherapy to treat acute mania. These are all first-line drugs. Patients may be treated with monotherapy. Expect that half of the patients will respond with significant improvement in 3 to 4 weeks. However, combination therapy may work better than monotherapy for acute mania. As we already stated, combination therapy may work better than monotherapy for acute mania. So combination therapy can include quetiapine, aripiprazole, risperidone, and acinapine, and those are in order of preference, with lithium or valproic acid. Adverse effects or adherence may be a problem with combination therapy. So you need to reevaluate the treatment after 1 to 2 weeks. Just so you know, valproic acid is also called valproate or divalproex. They are all used in the body as valproic acid. This slide includes a list of drugs in the order of preference used as monotherapy to treat depression and bipolar 1 disorder. These are all first-line drugs. Expect improvement after 2 weeks. Lamotrigine takes longer due to the need for slow titration. The drug that is effective for the acute phase is generally continued into the maintenance phase. The first 3 on this slide are the same as for treatment of bipolar 1 mania, and 2 of them, lithium and valproic acid, are used for depression and bipolar 1. These are also first-line drugs. Okay, for treatment of bipolar 2 disorder, hypomania, unless it's frequent, severe, or impairs function, Hypomania may not require treatment. For depression, quetiapine is the first-line treatment. Second-line pharmacotherapy options include lithium, lamotrigine, adjunctive quetiapine, and select antidepressants. Antidepressants seem to be less risky in bipolar 2 versus bipolar 1, and we're going to talk about that a little later. For maintenance, first-line options are quetiapine, either monotherapy as an adjunct, lithium, and lamotrigine. There are 3 classes of drugs used to treat bipolar disorder. The first class is mood stabilizers, such as lithium. Mood stabilizers relieve symptoms during manic and depressive episodes, but they also prevent recurrence of manic and depressive episodes. They do not worsen symptoms of mania or depression and do not accelerate the rate of cycling. The toxic trio consists of lithium, valproic acid, and carbamazepine. These 3 may cause hepatotoxicity and nephrotoxicity at relatively low doses, and levels must be monitored. Lithium is generally considered first-line treatment for all episodes and subtypes of bipolar disorder because it's highly effective for stabilizing acute mania, has the best evidence for relapse prevention and suicide prevention, and can improve hypomania and some cases of bipolar depression. Select anti-epileptic drugs are also considered mood stabilizers. The second class of drugs used to treat bipolar disorder is second-generation antipsychotics, also called atypical antipsychotics. These are useful during severe manic episodes and also in depressive episodes. The last class is antidepressants. These are sometimes cautiously given during depressive episodes because they may cause switching to mania. First, we're going to talk about lithium. Lithium is in the periodic table of elements. The precise mechanism by which it stabilizes mood is unknown. It's generally considered first-line treatment for all episodes. It's been the gold standard for bipolar illness for almost 60 years. It declined use during the 80s and 90s due to concerns over adverse effects, but there's currently a resurgence in use because recent higher quality studies comparing it to anti-epileptics and second-generation antipsychotics has confirmed its clear benefit in stabilizing 50 to 70% of patients with acute mania and its superiority to anti-epileptics for preventing manic episode relapse. Lithium's therapeutic effect for treating mania is about 7 to 10 days after initiating therapy. Now, for improving depression, it's about 6 to 8 weeks. Several adverse effects or responses occur early in treatment and then usually subside. The GI effects of nausea, diarrhea, abdominal bloating, and anorexia are common but transient. About 30% of patients experience transient fatigue, muscle weakness, headache, confusion, and memory impairment. Polyuria and thirst occur in 30 to 50% of patients and may persist. There are many others, including ones not listed on this slide. Before starting lithium, a clinician should make sure that the patient is not pregnant. Lithium should not be used in the first trimester of pregnancy due to its risk of cardiac malformations. It's sometimes used in the second or third trimester if the benefits outweigh the risks of neonatal hypothyroidism and floppy baby syndrome. A urinalysis should be obtained before starting treatment every 3 to 6 months for 1 year, then annually to monitor for lithium-induced nephrogenic diabetes-like syndrome. Lithium is 100% eliminated by the kidneys. It's best avoided in patients with unstable kidney function, although it can be used if the kidney dysfunction is stable. The risk of lithium-induced nephrotoxicity is about 0.5% and is more likely in those taking lithium for greater than 20 years. Thyroid function should be monitored at baseline, 1 to 2 times during the first 6 months, then every 6 months, because a hyperthyroid state can mimic a manic episode and lithium can cause hypothyroidism. A pre-treatment electrocardiogram to detect underlying heart disease is recommended for patients over 40 years of age, as lithium can increase the risk of arrhythmia. Reducing sodium intake may increase lithium levels. Patients should avoid adopting a low sodium diet. A CBC with differential every 2 to 3 months during the first 6 months, then annually, once stable, should be done. More importantly, lithium levels must be drawn. Lithium reaches steady state after 5 days of continuous dosing. Levels should be monitored closely. Every 5 days after initiation and dosage changes, and every 3 to 6 months during maintenance therapy or when clinically indicated, suspected toxicity, non-adherence, or drug interaction. Lithium blood levels should be obtained 12 hours after a dose. The steady state level is 0.8 to 1.2 milliequivalents per liter and a little bit lower in the elderly. Lithium toxicity is common and occurs in 75 to 90% of patients receiving long-term lithium therapy at some point during their management. It most often results from inadequate renal excretion. Toxic patients typically present with mild side effects such as hand tremor, but other symptoms like weakness, delirium, rigidity, hyperreflexia, altered gait, seizure, and EEG changes may also result. While severe lithium toxicity typically correlates with elevated serum levels, not all patients with high lithium levels present with advanced symptoms, at least in the early stages. This is due to delayed distribution within tissues. Similarly, patients with lower serum levels of lithium may present with advanced symptoms if the drug has accumulated in the cerebral spinal fluid to a greater extent than it has in the serum. The drug interactions with lithium are almost endless, but here are some interactions based on drug class. Diuretics promote sodium loss and then can thereby increase the risk for lithium toxicity. NSAIDs can increase lithium levels by as much as 60% by suppressing prostaglandin synthesis in the kidney. NSAIDs can increase renal reabsorption of lithium and also sodium, causing lithium levels to rise. Anticholinergics can cause urinary hesitancy. Coupled with lithium-induced polyuria, this can result in considerable discomfort. Bipolar disorder can be viewed as an aberration of mood, behavior, and cognition from baseline, which is euthymia. Below baseline is characterized by depression and subsyndromal depression. Above baseline is characterized by mania, mixed states, hypomania, and subsyndromal mood elevation. In contrast to the treatment options for mania, the options for depression are limited. Valproic acid, which is also valproate or divalproex, is as effective as lithium for acute mania, and may be more effective than lithium if a patient has a rapid cycling bipolar disorder, a substance abuse history, or symptoms of depression occurring at the same time as hypomanic, or manic episode, formerly known as a mixed episode. However, it is not as effective for depressive episodes and is not as effective as lithium during maintenance therapy. Valproate has often been better tolerated than lithium in clinical trials of maintenance therapy, with fewer patients discontinuing treatment due to adverse effects. Valproate has a wider therapeutic blood level range and is less toxic in overdose compared with lithium. The trough level should be checked 3 to 5 days after initiation or any time a dosage change occurs. Once 2 consecutive levels are within the therapeutic range, which is 50 to 100 micrograms per milliliter, it needs to be checked at least every 3 to 6 months. The thyroid stimulating hormone and liver function tests need to be looked at frequently during the first 6 months, and then the TSH, liver function test, CBC, and platelets at least every 6 months once stable. Need to avoid valproate in women during childbearing years unless a birth control method is assured. Lamotrigine is not effective for acute mania, but is still considered a primary maintenance treatment for bipolar depression and rapid cycling illness and for prevention of depressive relapse. Some of the other anti-epileptic drugs are second and third line mood stabilizers that we will not cover. Carbamazepine is another drug to treat from above. It's similar to other anti-mania options in that it's contraindicated in pregnancy and may cause sedation, hepatotoxicity, and pancreatitis. It differs in that it may also cause agranulocytosis and aplastic anemia. Carbamazepine induces its own metabolism, leading to increased clearance, shortened serum half-life, and a progressive decrease in serum levels. Increases in daily dosage are necessary to maintain plasma concentration. Lamotrigine, which is Lamictal, may also be used. It is not approved by the FDA for bipolar depression, but it is clinically the first choice for bipolar depression. It often causes a pruritic rash, so it's called Lamictal, and it can cause Stevens-Johnson syndrome. Second-generation antipsychotic medications are used to acutely control symptoms during manic episodes, used long-term to help stabilize mood, and can benefit patients with or without psychotic symptoms. They can be combined with a mood stabilizer. Antipsychotics recommended for use in bipolar disorder include quetiapine, aripiprazole, and asenapine, risperidone, and lurasidone. Quetiapine is recommended more frequently in the guidelines, so I do want to review its side effects that are common in many second-generation antipsychotics and the comparison of the side effect frequency to the other drugs in the same class. Quetiapine produces no extrapyramidal symptoms or prolactin elevation. It is likely, and very highly likely, not very highly, highly likely, that it will end hyperglycemia. It is moderately likely that it will produce orthostatic hypotension and sedation. All or nearly all of the second-generation antipsychotics have QT prolongation. Experts continue to debate the relative merits of antidepressants in bipolar disorder, given that their use during a depressive episode may result in a switch to a hypomanic or manic episode, and they may worsen cycling frequency, particularly in patients with bipolar 1 or any rapid cycling bipolar illness. Rapid cycling is another identifier used for those experiencing 4 or more episodes per year. This is a main reason why, as nurse practitioners, we need to be able to correctly diagnose patients and differentiate between depression and bipolar depression. Diagnosis and differentiating symptoms are discussed in another class. Although antidepressant monotherapy should be avoided in bipolar 1 disorder, some patients may benefit from combination therapy. The risk of antidepressant-associated switching seems lower in bipolar 2 versus bipolar 1 disorder. Antidepressants should be discontinued if hypomania, mania, or agitation occurs. Okay, so what about our nurse with bipolar 1 disorder in the beginning, our case study? First of all, you need to assess her suicide intent and if she has a plan. If you feel that she is not likely to be suicidal or commit suicide soon, you can start her on a low-dose quetiapine XR for depression, as that is what she's having now. And this is a schedule. You do need to titrate upwards. Now, for depression, this is a maintenance of 300 milligrams orally once a day. If they were manic, it's up to 800 milligrams maximally per day. Lithium treatment is very intensive for primary care. We can do it, but I think the psychiatrists seem to handle it more often, at least in my area, but it can be left up to primary care to monitor it, even though the psychiatrist prescribes it. Okay, key considerations. Lithium continues to be a first-line treatment option for mood stabilization. It's important to maintain coordination of care in patients on lithium therapy because of its narrow therapeutic index and potential adverse effects and toxicity. So kidney function is very important to monitor, and lithium can accumulate in renal impairment. Thyroid function can be altered by lithium, but be sure to monitor the TSH in a patient on chronic lithium. Over-the-counter NSAIDs can interact and raise lithium levels. This is something you need to watch out for, as patients can begin taking these medications on their own without supervision. They do need excellent patient education to avoid those. Be sure to assess lithium levels. Signs of toxicity can include GI upset, tremor, motor movement issues, sedation, and CNS changes. When we talk about the clinical pharmacology of atypical or second-generation antipsychotics, we need to think about some of the following factors. Mostly, the second-generation antipsychotics prolong the QT interval, so they should be avoided with other drugs that have the same effect, namely the SSRIs, fluoroquinolones, macrolides, and amiodarone. And then antidepressants may cause switching to hypomania or manic episode or worsen cycling frequency. Thank you for your time and attention.